Welcome everybody to this forum, and first of all I'd like to acknowledge the traditional owners that we're on Aboriginal land, and we acknowledge the Wurundjeri and Boonwurrung people of the Kulin Nation, whose land we are joining from, and pay respects to elders past and present. Welcome everybody. We've had an enormous amount of registrants, some in close to 300, and if they all join, it'll be just a significant response to an issue that we feel is extremely important. My name is Eddie McAleff, and I'm the chairperson of the Ethnic Communities Council of Victoria. And I'd like to welcome our keynote speaker, Steve Dimopoulos, the Parliamentary Secretary for Mental Health, and also our panel members. We're looking forward to their contribution, Dr. Francis Acquah, Dr. Judy Tang, and my old friend Paris Aristotle. Any other significant attendees, Chris? We're very excited to host this event and welcome everybody. As I said, mental health is a significant priority for the ECCV. We've been working to contribute to the Royal Commission and its mental health reforms, its signal. Even before the coronavirus pandemic, we knew there was a lot of hidden mental health issues for migrant and refugee communities. The pandemic has certainly brought those issues to the surface. Since the COVID pandemic, it's had a major impact on mental health. It's well known and acknowledged. Lockdown pressures, financial pressures, social isolation, increased racism, pressure on working parents, worries for families overseas, have all made these issues more stressful. We acknowledge that the lockdown at the moment is creating mental health challenges. So we expect that the mental health reforms can contribute to changing this situation. The Royal Commission found the mental health system in Victoria is broken. And I'll say that again, it's broken. The system is failing to meet the needs of our increasing diverse community. And very much to the credit of the Victorian government, the Royal Commission recommendations, we commend the government to this commitment to action. The ECCV is proud to bring this conversation together and how we have implemented the Royal Commission's recommendations and what is needed to make the system more culturally responsive. The way the subject of our joint paper, this was the subject of our joint paper, with the Victorian Transcultural Mental Health Service. The paper goes through what needs to change in policy and make recommendations of how migrant and refugees community and our multicultural sector need to be involved in this change. We'd like to acknowledge the forum is supported by the Victorian Department of Health. We also like to acknowledge the work of the Victorian Transcultural Mental Health Service, who unfortunately are unable to join with us today. Our keynote speaker, which I'm introducing, is Steve Dimopoulos. Steve is Parliamentary Secretary to the Premier and Parliamentary Secretary for Mental Health. Since being elected as the member for Oakley in 2014, Steve has served as Parliamentary Secretary to the Treasurer, been a member of several committees, including the chair of the Mental Health Expert Task Force. Before entering Parliament, Steve had various positions with the Victorian Government, including Assistant Director of Court Services with the Department of Justice and Regulation, Victoria, and Manager of Policy and Programs at the Victorian Multicultural Commission. Steve is a former Mayor of City of Monash, has local government experience. So Steve, we welcome you and thank you for making the time available to speak to us. We will have a short time for some questions and answers after he speaks. So Steve, welcome and go ahead.
Thanks so much, Eddie. Thank you for that warm introduction. Thanks everybody for being here. What an incredible attendance for this important forum. Before I begin, I'd also like to acknowledge, as Eddie did, the first peoples and custodians of the lands upon which we meet today, wherever we are, and pay my respects to the elders past and present in what is the world's longest continuing culture. I want to also acknowledge in this forum particularly people with lived experience of mental illness and the experience of people who've been carers, family members or supporters of those with mental illness. Some of the most powerful evidence to the Royal Commission into Victoria's mental health system came from those very people, personal experiences of people living with mental illness, their families and carers. Also acknowledge their extraordinary determination and courage. They've laboured under a system that hasn't worked, as Eddie said, it's been broken, and their courage and their foresight to work to build a better system for themselves and the people they love. I want to acknowledge Chris, obviously Eddie I've acknowledged, Chair of the ECCV, Chris, Executive Officer of the ECCV, and Dr Francis Acquah, Clinical Director of the Positive Mental Health Program, and Paris Aristotle, of course, AO, Chief Executive Officer of Foundation House. And I think Dr Judy Tang is here as well, clinical neuropsychologist, and also a member of the BMC, is my understanding. So welcome everybody on this call, in this meeting. So it's a pleasure to be here for many reasons. This community is one that I've grown up with, both in a sector sense, but also in a lived experience sense, being of a Greek background, but also because mental health is the biggest issue in town for this government. I want to thank Chris and the team at the ECCV for inviting me to speak with you about the work that's already started, but the work that's to come as well as we begin this 10-year reform journey to fix Victoria's mental health and wellbeing system. These are once-in-a-generation mental health reforms. We hear that a lot, but this is absolutely one of those occasions where that wording is warranted. These reforms will transform the lives of Victorians, all Victorians, no matter your cultural background, your place of birth, or where in Victoria you live. We know that the mental health system is facing major challenges, always has, but it is facing major challenges today in coping with rapidly increasing demand. Finding the right service that can help you or your loved one is difficult, and waiting lists are long. Many people have to travel long distances to get help and miss work or school in order to get the care they need. And for some, the lack of culturally appropriate information, resources and support means they can't even take the first step of asking for help. Or if they do, the help is not appropriate. Far too many people continue to fall through the cracks of the mental health system. And of course, this pandemic, as Eddie said, has only exacerbated the issue. We know that the pandemic has disproportionately affected Victoria's migrant and refugee communities. This is especially true for people experiencing socioeconomic disadvantage or challenges stemming from insecure work, housing or visa status. Faced with a mental health system that is fragmented and difficult to navigate, people from multicultural communities are experiencing higher levels of psychological distress. Our mental health service and the vital workforce that care for and support people in need are both stretched to their limits. And for many people in our community, whether because of where they live, their cultural and language requirements, discrimination or other circumstances beyond their control, simply cannot access the care, treatment and support they need. The costs have been and continue to be high. If you think about it, the cost of lost human potential, the cost of a life not well lived, the cost of pain and suffering for years in and out of rigid service systems, impacting and traumatizing the person seeking help and the people that love them. We decided that we would try and do something about this as a government, not in a piecemeal way, but through wholesale system reform. The Royal Commission into Victoria's mental health system, which we committed to in October 2018, has provided the blueprint to create the system that we need and deserve. We can't fix a decades-old system in a year, and nor are we expecting to. But work is well underway on all 9 of the Royal Commission's interim recommendations, which were handed down in November 2019 on the cusp of the pandemic. We've also started delivering some of the most urgent reforms outlined in the Commission's final report released in March this year. Together, the recommendations in these 2 reports, 74 of them in total, lay the foundations for a new approach to mental health and wellbeing, one that will transform how mental health care is designed and delivered in our state. We knew that doing justice to the Royal Commission's recommendation would require record investment. That's why this year's budget, 21-22 budget, invested $3.8 billion into mental health and wellbeing, into a mental health and wellbeing package that will make treatment, care and support available to more Victorians when they need it closer to home. And that commitment is on the back of last year's budget, which was only in November last year because of the pandemic, which committed to $869 million for mental health reform and immediate service delivery as well. So with last year's and this year's budget, we've cumulatively invested $4.6 billion over a 5-year time frame into building our new mental health system just in Victoria, $4.6 billion. To give you a sense of perspective, this is almost double the Commonwealth Government's investment for the whole country. Not everything the Royal Commission recommended has been funded this year, and it couldn't possibly be. But we will implement every single recommendation. The Premier's committed to that many times, as has the Minister. This is a 10-year reform journey, as I said. The Royal Commission's final report was informed by over 12,500 contributions from people and organisations, including some of you here today. It was the largest ever contribution by the public in any government inquiry. While there are recommendations in the Royal Commission's report that speak to specific groups, communities and circumstances, most recommendations are focused on the systemic, structural and cultural changes that will need to deliver our new mental health system. At the heart of the Commission's vision is a system that is designed in collaboration with the people that will use it. One that is culturally safe and responsive to people's individual needs. And this does not just mean their individual clinical needs, but their individual context and humanity, including their cultural and linguistic context. People from migrant and refugee backgrounds will have a critical role in contributing to the design and delivery of this new system. While only one recommendation in the final report explicitly addresses the needs of diverse communities, it speaks to the need for these communities to be engaged across the entire reform process. The recommendation says, and I quote, ensure the active engagement of Victoria's diverse communities throughout the process of planning, implementing and managing the reformed mental health and wellbeing system. Let's have a closer look at these elements: engagement, planning, implementation and management. I'd like to use the 4 themes as a guide to talk you through some of what we're doing to deliver on this recommendation and how we will be engaging both the ECCV but also the Victorian Multicultural Commission as a governance leader in these across these communities. Firstly, engagement. We want to make sure that diverse communities and sector stakeholders can actively and meaningfully engage with aspects of the reform that matters most to them. We're currently working through how to do this most effectively and make sure that we're engaging the right groups and a broad range of voices to capture the diversity across and within our diverse communities. The engagement strategy will also coordinate and streamline our approach to working with community groups and organisations so that we can avoid overburdening particular groups. In the coming months, we'll be taking the first steps towards engaging the multicultural sector, including multicultural service providers and ethno-specific and faith-based organisations. The ECCV will be a key partner in this work to help us connect with organisations and groups like the ones represented here today. And that's why this forum is actually really well timed. We know that our engagement activities must be truly accessible and take a range of forms if they are to be successful, because even at the point of engagement, you could have cultural biases. They must address and remove any potential barriers for participation so that people from all communities can safely and meaningfully contribute. We will develop a range of ways to engage on different reforms. Channels will include forums, roundtables, and digital platforms. It is particularly important that culturally diverse Victorians with lived experience of the mental health system are able to participate in these conversations, and in particular in co-design processes. We welcome the ECCV and the VMC's ongoing advice and guidance and leadership on these. We are also finalising a range of new and refreshed advisory functions to support the reform. These will include a mental health ministerial advisory group reporting directly to the Deputy Premier and other committees that will focus on different parts of the reform and provide advice. There will also be a number of working groups that are formed to directly co-design services. With all of these, representation by culturally and linguistically diverse communities and their leaders and advocates will be essential. We will be working with the ECCV and the VMC to ensure that these advisory functions are set up in the best possible way. And they're not too far down the track farther. They're not too far before they're announced, I think in the next couple of months. So now we move from the engagement stage to the planning stage. We're in the process of planning the range of initiatives funded through this year's state budget. We know that the whole of diversity approach is not enough and that we must address the specific and unique needs and challenges of people from migrant and refugee backgrounds. And of course, our multicultural communities are themselves diverse, so the framework will need to account for the differences both across and within our communities. This includes looking at the intersecting needs and experiences of individuals and how multiple forms of discrimination and disadvantage can compound the risk factors for mental ill health. The first step in the significant piece of work will be the establishment of the Diverse Communities Working Group, which will guide the development of a diverse community's mental health and wellbeing framework and blueprint for action. That was a recommendation of the Royal Commission. We are committed to work with the ECCV to develop a really robust engagement process to develop these important strategic plans. You may have seen this in this year's budget. We provided funding to support community organisations and peak bodies to engage in the mental health reform process, and we need to do more of it. We're working hard on designing an equitable funding process that ensures the impact and reach of this funding is maximised. We want to make sure the funds can address different and intersecting needs across Victoria's diverse communities and support a mix of activities. This funding recognises the important role that community organisations and community leaders play in supporting the mental health and wellbeing of their communities. I want to quickly touch on some of the other important opportunities for engagement across the broader reform program. And this is only a snapshot because we don't have the time to go through every aspect that we will engage multicultural leadership and communities on. There'll be a significant opportunity to build on cultural responsiveness across several initial reform pieces, including the local area services. We're setting up 50 to 60 local area services across Victoria. They're sort of at the base of the pyramid of service delivery, and there'll be 22 of them were funded in this year's budget. Regional commissioning, we'll have 8 regional boards developed across Victoria that will be responsible for purchasing or commissioning services for their communities, rather than it all coming directly from 50 Lonsdale Street, the Department of Health. So a bit more of a responsive delivery model across Victoria. Workforce development and capability, one of the biggest challenges, and the new Mental Health and Wellbeing Act. Supporting the cultural responsiveness of mainstream mental health services will be another key priority. We already have some wonderful examples of how services have customised the support they offer to meet the needs of diverse communities. For example, the Life-Saving Hospital Outreach Post-Suicidal Service, or HOPE, recognises a critical role that community and cultural leaders, elders in Indigenous communities and extended families play in healing and recovery. The service actively engages those support networks when caring for a person who has attempted suicide. The HOPE team is made up of both clinical and social support workers, including peer and lived experience advisors, and care is provided based on the initial individual needs of the person and their support network. We'll also actively explore the role of community leaders and organisations in mental health and wellbeing promotion and prevention work. This will include mental health literacy and anti-stigma work, access to interpreters and translated materials, and developing a more diverse workforce, including peer and bicultural workers. Moving to the implementation and management and how multicultural migrant and refugee communities will contribute to this, the ongoing improvement of the mental health and wellbeing system. Many of the reforms included in the final report of the Commission are still some way off being fully implemented, as you'd understand. So we're still in the early stages of working through what this will look like. However, the Commission was very clear about a few things. First, the mental health workforce should be representative of the diverse population it serves. Secondly, people with lived experience will have a significant role in the design, delivery, and evaluation of mental health services. And thirdly, people from diverse communities, including those from migrant and refugee backgrounds, will be actively engaged in the entire reform process. This engagement doesn't end when ribbons are cut and services are launched. Another critical element of the reformed mental health system will be the ongoing evaluation of services, focusing on the experiences of the people who use them. Again, we will be able to tell you more in the coming months about what this will look like with your help and guidance. This is just the first step in a 10-year journey. We're working across the Victorian Government and with the Federal Government on some aspects to bring this vision to life. Soon you will start to hear more about the initiatives I've spoken about, including the Diverse Communities Working Party and mental health and wellbeing framework, and the advisory structures we're putting in place to ensure that the voices of Victoria's diverse communities are heard. You'll start to see some of these opportunities to contribute to the direction of the new services and initiatives. Some of you may have already provided feedback, for example, on the draft Mental Health and Wellbeing Act, which is open for public consultation now on the Engage Victoria website. And I think it closes on the 1st of August. The new Act will reset the legislative foundations for the mental health and wellbeing system. It will help ensure that mental health services that are responsive are at the forefront of service design and delivery. I know that the ECCV has developed a useful resource to support members to make a submission to the Act. We welcome your contributions, and we will continue to work closely with the ECCV members to ensure that Victoria's multicultural communities are engaged at every step in the process of rebuilding our mental health and wellbeing system, starting with the engagement structures at first and moving to the service delivery and co-design elements of the system. I want to take this opportunity to thank you once again for inviting me to join you here today. There's a lot to be said. This is purely the start of the conversation. I'm proud to share with you the steps we're taking to create a safe and responsive mental health system for all Victorians. But when I say we, I mean all of us. This is truly one of those social policy reforms that cannot be delivered by government alone. You will all be partners in delivering on these reforms. My deepest thanks to those of you who've already contributed to this reform journey. I look forward to working with you to build the mental health system that Victorians need and deserve. And you can rest assured that the Minister for Mental Health, who was also the Minister assisting the Premier of Multicultural Affairs, has a strong affection, and being of Italian heritage as well, has a strong affection to the engagement and the proper and genuine engagement of our communities, our diverse communities, in the design of this new mental health system. Thank you very much for the opportunity to speak with you today.
Thank you very much, Steve, and for outlining the vision and the program for the future implementation of the reforms that are much needed. Do we have any questions before I hand over to Chris to moderate the next part of the session?
Thank you, Eddie. I think you know, with 170 odd people in the room, I think it's important that you know, people put up their hand, their virtual hand, through the reactions button to, and I'll just call your name out, and feel free to ask your question of the Parliamentary Secretary. But I'd also like to thank you, Parliamentary Secretary, for making time for us today in our sector, and really for painting the picture of the big vision that the Victorian government has for engaging the multicultural sector and diverse communities across our state. So can I ask for questions that that people would like to ask? Put your hand up, please. Someone's got to be brave enough.
After a year of may I speak through the chair?
Who is it? Can you put
Alexander Abramov. I can't remember how to put up my virtual hand.
Go ahead, Alex.
Thanks, Eddie. Thanks very much. Thanks, Steve. Hello, everybody. I may as well go first and state the bleeding obvious. Being a group of ethno-specific and multicultural providers, Steve, what's the government's intentions on quarantining or specifically allocating money for mental health programs that are specifically allocated to the called community? Because often that sort of funding, the big mainstream providers, you know, put up their hand and put in great submissions, and then utilize the intelligence on the ground, the grassroots of the ethnic communities, and sometimes throw them $100, sometimes not even that, in order to build their programs, in order to contact the communities. So,
thanks, Alex. It's a good question. I don't have a specific answer in terms of quarantining funds, but if you, and I may sound optimistic, and I'm conscious of that, but if you put the equation the other way, you actually have a engagement process which absolutely does co-design service delivery with multicultural leaders. I find it very hard to see a situation that develops in terms of funding down the line, which doesn't then come back to ethno-specific organisations. I've had, I mean, Beyond Blue and Lifeline, and just picking two mainstream service providers in one end of the spectrum, not to mention a whole range of others. They did great work. We all know that. But I'm also conscious that I've spoken to some people in this room who have already well-developed relationships with clients or customers or consumers, and on other service delivery aspects, not mental health at all. But then they've told me that those consumers feel much more comfortable going to those same providers for mental health service delivery, for example. And I think those kind of cultural, we don't see sometimes those cultural kind of barriers in system design. We think, well, you know, everybody should be able to ring 13 numbers and just press 6 for interpreters. It doesn't actually work that way. The stigma, feeling safe and comfortable, and the pathways to access a lot of these supports rely on existing relationships. So I'm with you on what you said, which is effectively, I think, not trying to put words in your mouth, that the service system, and this sounds really basic, but it's fundamentally true, the service system requires participants across the entire spectrum. Mainstream service providers have to be more competent, culturally competent, but they can't do the job on their own.
Oh, I'm glad everyone else wasn't thrown out of the meeting, but it's good to see you again. So, so thank you for covering. So, who was next? Was it JR?
I'm happy to go next. Thank you, Steve and ECCV team. My question is, how much do you think has been put towards primary prevention, or has that been at all factored into to put quite a bit of money into primary prevention, such as social support programs, which we know really work well with ethnic groups? And has that been considered in the mix?
It is definitely being considered, and again, I don't mean to say this in every response, JA, but it's fundamentally true. We're actually designing the system over the next sort of 6 to 12 months in the initial phase, and then ongoingly. So I don't have those answers now because they really rely on the engagement we have with you and other people. But it makes intrinsic sense, and the kind of the spirit of the recommendations and the government's aspirations are exactly on that model, because the Premier's often said, you know, one of the key things the Royal Commission found, which sounds so intrinsically true now, but it's the fact that you have a whole bunch of eminent people come together to contest this with 12,500 submissions and to still come up with the basic tenet, which is we want to treat people early in the community rather than late in hospital. You know, fundamentally, mental ill health does not start at the acute, in an acute bed in a psychiatric hospital. It starts in the family home, it starts in the sporting club, it starts at school, it starts at the workplace, it starts in the community. And that's exactly where we need the best intervention. So with those 50 to 60 local areas, facilities we're going to provide around Victoria, so support services, and there'll be more than just a building, there'll be outreach. We are keen to have a social prescribing kind of aspect to that. So there'll be a bunch of support available for organisations to provide that social prescribing. So whether it be multicultural organisations, it could be men's shed for sort of the other element of the community. So yes, I'm not sure if I've answered your question, but that is our aspiration, absolutely, because that does work. It's early and it avoids a whole world of pain if we try and support people at that stage.
No, thank you. It does answer my question. Yeah.
Thank you, Jaya. Shelley, I can see you next.
Excellent. Thank you. Thanks, everybody. I was just wondering, you were talking about sort of the diverse workforce. So I'm going on a different tangent now, and I think that's awesome. But there's a lot of hurdles for us in public health to try and recruit to that, because there's a system in place called computer match, and you have to go through state, and so there's sort of, as far as recruitment, it's really hard, and plus all the sort of the visas and things like that. So is there anything that can be done in that space? I know it's a big question.
Yeah, I think well, again, it's really easy. Ask me in 2 years' time when we've had 2 years digested. I won't have the easy cop out of saying, well, it's up to people like you to give us those kind of answers. But fundamentally, we have one of the key requirements with an actual deadline. I think it's December this year, is to develop a workforce strategy. That was asked of us by the Commission. We're doing that now with industrial partners and others. There's a couple of aspects to it. One is a peer workforce, but that alone can't meet the demand. The peer workforce is a great addition to the workforce, and also it's a healing journey for many people with lived experience. But I think in terms of culturally diverse workforce, frankly, this is my personal view. We need borders to reopen. In due course, when it's safe to do so. We need to tap the internal untapped resource of the population in Victoria and national in Australia. People who've never seen themselves working in mental health service system, actually finding it interesting and compelling. We're doing some things initially by offering free TAFE courses, for example, Cert 4 in mental health peer work. We're probably going to expand those offerings, but in addition to that, the stigma is part of that journey. The more you destigmatize the system, the more I think it is more compelling for a future workforce to say, yeah, look, I actually want to work in this system. And it's well resourced, it works, it's fundamentally not flawed. People don't get this exodus because they're just exhausted. All those things come to bear. In terms of sort of funding relationships, I think you hinted with government, that's going to have to change as well, because there's a priority we need to get to in terms of the workforce. So we're not going to be hamstrung by contractual and other matters. They need to operate in a way that achieves the aspiration that we want, not the other way around. The stymies that. So yeah, I'd love you to connect you with the people who are doing more work on the workforce strategy. So if you wanted to send me an email, I can connect you, because you've obviously got a specific lived experience with that would be helpful.
No, that'd be great. Thank you. Yeah, there's a lot of work that we could be doing. So
yeah,
that's good. So I'd appreciate that.
Yeah, thanks,
Thank
Shelley.
you.
So I have something to say. Are we allowed to ask questions now? Are you?
Ursha, sorry. Did you have your hand up next, or go for it?
Yeah. So you know how we're talking about the mental health system. I really don't have it's like a question and a statement at the same time. And I'm not making the statement out of little knowledge. I've actually spoken to a lot of people within my community, seen them experience things, and I've experienced mental health issues as well. The problem that I see here is not about the funding or what we're going to do with it, but it's more about, how organizations like Department of Health or Department of Justice, they like to work in silos. And of course, they are more than entitled to work in silos. The problem is when there's issues such as that are as sensitive as mental health, especially within the college communities, mental health is already a really huge stigma. And so if you're working on that topic, you should work together just to provide a specific perspective to people or a specific outcome, Otherwise, it's not going to help out anyone.
Agree. Can I say, Fasha, I agree that, and silos are a problem in most places, but that's something we have to be conscious of. Interestingly, when you look at silos as well, we're trying to, and there's different theories about this and different views, but we're trying to avoid silos in the engagement and consultation kind of governance apparatus of this reform journey. So even how we establish the kind of governance arrangements around co-design and around policy advice to the minister, we're trying to avoid just having silos. But having said that, though, there are a couple of key groups that, or one key group that will maintain. They're not silos. We hope will converge somehow in a governance framework that works, and that is the clinical group and the lived experience group. So lived experience got a really strong a strong currency in the recommendations of the Royal Commission. So there'll be a specific advisory group around made up of lived experience Victorians, but it should be multicultural representation in my view, at equal levels to the Victorian community. Not just if you're going to have 20 people on this lived experience group, as an example. In my view, it's not good enough to have 2 people of a cultural linguistic diverse out of that 20. We need a sizable number, but I'm conscious of the silo argument, and we're going to try and be far better.
I made that statement. I just have a very
sorry, Esha, we're running out of time. I think we're just trying. Thank you.
I'll keep my answer. Sorry, I'll keep my answers very shorter, Chris. I'm sorry. I keep going on.
No, not at all. Not at all. We've got time's running out, so just conscious of that. I think we'll take. I believe Alba has a physical hand up, so I might throw to you quickly, Alba, and then see if we can get through Tanya, Tina, and Francis, and we might have to call it time there. Alba, over to you if you're there. No. Okay. Well, Tanya, I'll throw over to you then.
Sorry about that. I had it. My key concern is when it comes to mental health, carers are fundamental at the center in terms of being in a good space, not only for youth, but also for seniors. I would like to know if the system in the future will consider the whole family as a core in actually supporting mental health, because it can be sometimes even the opportunity to prevent mental health issues.
Albert, thank you. I'm glad you reminded me of that. Absolutely, it will. And, we've always got to balance the kind of priority of the individual consumer and their rights, privacy, the rights to their own journey in terms of treatment, but have an access point to the family. One of the recommendations of the Royal Commission that I should have perhaps mentioned earlier was actually to establish I can't remember the terminology to be honest with you, but effectively a pathway for family and advocates to have a say in the service system. And I was really, really chuffed to read that in February, March, because of I had a family member who I was an advocate for, not the primary advocate, but definitely an advocate over years. And I think I said in my notes, in my contribution before, that the system has not just traumatized the consumer, it's traumatized the family. And it's really, and they feel lack of access. They ring and they get short shrift because the clinician can't talk to them, and a whole range of other things. So there's a strategy around that, and I'll have to pull it out, and I'm happy to send it to the ECCV to pass on to you. But it'd be great to have your contribution to that as well.
Brilliant. Thank you. Tanya?
Hello, Stephen. Hello, everyone in the room. Thank you so much for this opportunity. I suppose for me, having been just a few years ago part of deinstitutionalisation back in the day, and still having these discussions with colleagues, and I was a grant in aid worker, ethno-specific, and now I'm in private practice. These are discussions we have every month at supervision with a really wonderful peer group, and some of us are academics also. So I suppose my query is there room in this space for those of us that are in private practice? Because I will, for example, my own experience, my average age of client group at the moment is 60 to 85, and on mental health plans. There's no real wraparound service. I am one that works out of the box, lots of advocacy, and I get in trouble, but I'll still do it for the client, because there really is, I'm tend to get a lot of people that are coming through the cracks. But I'm keen to see, will, for example, those of us that are accredited mental health social workers or psychologists, for example, going to be part of this this change?
Yeah, absolutely, Tanya. Again, there's so much to say, and thanks for reminding me. I'll be very, very brief. But The Commonwealth's also committed to this. We've been negotiating a bilateral agreement with Victoria and the Commonwealth. Mind you, would have loved a lot more money. This Commonwealth government has valued mental health more than any other, in my view. But the money, unfortunately, nowhere near what we need. But nonetheless, one of the big focuses of that bilateral agreement, and also of our 50-60 centres, is multidisciplinary teams. So it takes an entire team of professionals to keep the community safe at that end of the spectrum, but right through to the acute end. So psychosocial support, a whole range of other things. It's not just psychiatrists and psych nurses, really. It's far more deep than that, and that will be part of that's the thinking now for those 50 to 60 centres. And then you've got the next escalation, which is the local area, the sort of regional area services. Then you've got the statewide acute services. Throughout that spectrum, that's why the workforce is so difficult too, because it's bigger than just the strict clinician definition. Equally, the last thing I want to say about that is part of it, our problem as well, is that in terms of whether it be your profession or others, many of the requirements for someone to graduate in a course is to have supervision, and then you've got an entire cohort of professionals who are busy already, not able to afford the time to provide that supervision. And then you've got the kind of chicken and egg argument. You can't graduate the new workforce because you haven't got the people to supervise them. And so we're going to need everybody. And I know it sounds really pedestrian, but it's so fundamentally true.
Look, I'll just a quick response to that. It's interesting because I'm an accredited supervisor too, 20 plus years. So I'm part and parcel of parallel, really do clinical work and do that too. So really support it. And thank you so much for that response, Steve. Look forward to it.
Thank you.
Tina, quickly throw over to you.
Yes, thank you. It's more a statement. Hi, Steve and everybody, and thank you for your time. My statement is more around sort of the funding and looking at that funding model. And Steve, you've referenced ethno-specific and multicultural organisations and the role that they play with working with communities. And I think that any model going forward, really, we can't have those short projects. I think there's a place for those, particularly when there's emergency and critical situations like in COVID. But if we are to look at a system that's going to have impact and provide service solutions to our communities, it needs to be a lot like the mainstream, where there's opportunities to actually invest in the intelligence, in the workforce, in the activities that we're doing that are making a difference to communities. And so ethno-specific and other organisations of the like in migrant and refugee communities need to feel like they're part of a service system. We're not add-ons. We should be able to have significant impact in the same way, and the funding model, whether it's at the Commonwealth or state, should be able to afford all the service leaders and all the practitioners to be able to have impact to the people that they work. It's just a statement. Yeah.
It's a great statement, and I couldn't agree more. And short-term funding is historically bad for many reasons, but in terms of trying to build everything we're talking about, a seamless service system, one that's actually responsive, one that's mature, one that is sophisticated, that understands, and to have a workforce around it, you can't do that on yearly funding. You can't. So they're the kind of things where you have to co-design together. And your one conversation you and I had was also part of, I didn't reference it when I gave the contribution at the beginning, but about where some of your clients, as well as other ethno-specific organisations, would rather ring your service when they've got mental health complaints or need some support, mental health support, rather than ringing a complete new service like Lifeline or Beyond Blue, new to them. Yeah. So they're the kind of but there's a range of those. I agree with you, Tina.
Thank you.
And lucky last, Dr. Francis.
Thank you very much, Chris, and thank you, Steve. Basically, what the two previous speakers have just been saying, and as a credentialed mental health nurse, this is an opportunity that the federal government have lost. We were not recognized during the COVID period in terms of any funding. But more importantly, it's about engaging with services that, or people who are providing services, especially for the COD community, who are not receiving support from the mainstream. And I can give you lots and lots of examples, but this is our first engagement, and we will have a long discussion around this. But the question is, how can you partnership with these small agencies who are doing the direct work? I have my phone on 24/7, but I'm not a CAT team. And that's when my clients actually call me, sometimes as late as ever.
Yeah, it's a great point. They're the people that are often not captured in the data either. So when a mainstream organisation, they do excellent work, but when a mainstream organisation then goes to government for a funding request, they represent data in a particular way. It may not capture the people that call you at 11 p.m. at night, or in fact, I'd argue they don't. Data collection, not that you were talking about data collection, but data collection is actually another requirement. One of the other things, pieces of work, it's a very expansive Royal Commission report. But Dr. Francis, I'll leave it with these 2 points. One is the co-design, hopefully, that we're going to do together will help mitigate some of the kind of pitfalls we've gotten into in the past in not supporting organisations, people, individuals and leaders like yourself. And number two, it's not, as I said, setting it up and then letting it go. It's actually having a continuing monitoring system. Light touch, it depends on how much people want to be involved. We can't burden people who have full-time work and families with monitoring a system we set up. But the opportunity to monitor and evaluate the system ongoingly is there. It's actually a requirement of the Royal Commission. So can I just say, Chris, I'm not sure if that's the last question. I just want to just invite you to, over the next couple of months, you should see a framework, a governance framework come out from the government, which goes from the Ministerial Advisory Committee I talked about right through the perspective of co-design working groups and those kind of other elements. I'd love there's 170 odd people on this call. I'd love your contributions to either being members of that or referring other people to be on those forums. And that's just one aspect. They're the kind of the continuing governance structures. But as I said with the Mental Health Act, there's bits of engagement for different strategic plans that happen in and out of those. So I'd love your participation. I haven't got anything concrete to share with you about those governance arrangements now, but they're coming in the next couple of months. So I'd love you to participate, whether it be through the ECCV or through your own accord.
Steve, thank you so much. You've been very generous with your time, thoughts and encouragement as well for the broader multicultural sector that's here today. And I think on behalf of everyone, we're really looking forward to working with you in the Victorian Government and the Department of Health around the reform process.
Thanks so much for the time. It's a real privilege and a pleasure to spend time with people that are going to help us reform the system. And what a great attendance. Thanks so much, Chris and Eddie. Thank you.
Okay, brilliant. Now thank you everyone for your great questions as well. Really some poignant discussion. We're about to move into our panel discussion, and we have quite an eminent panel, although Judy Tang is running, unfortunately, slightly late this morning, so we're hoping that she'll join us at 11:45. But I guess before I introduce today's panel, I'd like to acknowledge our recent work with Victorian Transcultural Mental Health, who, as Eddie said, unfortunately couldn't be here today. They've obviously been leaders in transcultural mental health for several decades and play a really important role in terms of specialisation and workforce capacity. And they've contributed a lot to us and through that recent paper that we published. So just want to give them a bit of a shout out. There was a bit of a clash and they couldn't unfortunately be here for today's panel. So without further ado, I'd like to welcome our panel for today. Dr. Francis Acquah, who you've just heard from, who's the Clinical Director of Positive Mental Health Program and President of the Mental Health and Wellbeing Foundation, and a psychiatric nurse with more than 30 years experience, and also a great friend of the ECCV. I'd also like to welcome Paris Aristotle AO, obviously eminent and well known to us all, CEO of Foundation House, who has more than 30 years experience in the field of supporting refugees and asylum seekers through trauma-informed practice. And finally, when Judy's able to join us, you'll get to hear from Dr. Judy Tang, who many of you will know as both a VMC commissioner and a board member of the Victorian Pride Centre. But she is a clinical neuropsychologist with her own practice, Jurmaine Health, and who's been a very strong advocate for multiculturalism and LGBTI communities for many years, particularly in the area of psychology and mental health. So I'll throw over to the panel. We've got some questions for them, and hopefully they'll be able to engage in a bit of a dialogue around some key questions this morning. And then there'll be a chance for some questions from the floor as well. I can't see you, Paris, but I can see Francis up on the screen. There we go. So thanks again for your time this morning. Very, very generous of you both. And Judy will join you as soon as she's able to come into the meeting. First question is regarding the Royal Commission's report. What are some of the most important recommendations in your view that the Royal Commission made? We'll throw over to you, Paris, first.
Oh, okay. I was about to handball to Francis. Thanks, Chris, and thanks for the invitation and for pulling this forum together. It's been really interesting, and it's just great to see ECCV taking the lead on these issues in the way you are. So thanks very, very much for that. I guess the first thing to say, without naming a specific recommendation, is I think the most incredible thing about it was what Steve had talked about. It was a recognition that the system was broken as a whole, and they haven't just gone for tweaking the old system in order to try to improve a few things. They've basically recognised that this requires dramatic reform across the board, and they've recommended essentially a whole new system. Now, I think that's a really brave thing for a government to both initiate a commission and commit to implementing the recommendations even before it's done. But then in receiving the reports, committing those resources and all of those things have been outlined this morning, for me are the most significant things about the Commission. The real problem is that the work begins now, and how do we keep or live up to the aspirations that are kind of that run all the way through the Commission report. For me, from our own organisation's point of view, the recommendations around recognition of diversity in called and refugee communities and other diverse communities was a really important factor. So the Royal Commission pulled it out and named it clearly and unambiguously, and even gone as far as recommending that the Secretary of the Department of Health be accountable by law for the responsiveness to called and refugee communities and ensuring the system overall deals with questions of diversity. That's never really happened before. It's been clearly stated in policies, but it's never really been enacted legally. So I think they're really impressive signs, and those recommendations about incorporating people from called and other diverse communities into the design and development of the program is really important. I think we are going to have to contribute a lot to those issues, because even with a stated commitment to doing it, that's different to understanding what it actually means in practice. And all of the people participating in this forum are the sorts of people that will be able to contribute to that. So hopefully we can find ways through those different mechanisms and advisory processes that Steve talked about to make sure we can do that. The other area for me that's really important is what it says about workforce capability and building the capacity and the professional development. For many years, the workforce has struggled to meet demand, but also it hasn't really been representative in the way it operates of just how diverse communities are. And sometimes you would find that even in areas where the catchments of the mental health programs clearly demonstrated very high levels of people from culturally and linguistically diverse communities, it wasn't always reflected in their data if they collected the data in the first instance. So those sorts of recommendations are great because it sets us up to be able to have a clearer picture of where the gaps are into the future. And so that's important. I guess the last recommendation, I mean, there's lots in the report, it's a huge report, but the last one that I would like to emphasise, of course, from our perspective is the relationship that trauma plays in terms of people's mental health and well-being. And for our own experience in working with refugees and asylum seekers, we know it is fundamental to people's the impact on people's mental health, and dealing with it in a trauma-focused way becomes fundamentally crucial. But in acknowledging well-being as the other part of this dimension, I think that's been an important recognition, because we know that people's mental health is not just about their intrapsychic worlds, it's about their external worlds, and how, from a well-being perspective, the broader social and economic determinants of health and mental health play a part. So that whole focus on trauma-informed practice, it relates to domestic violence, it relates to sexual assault, and a whole range of other things. And someone's just started to mow the lawns outside, so I might go and do something about that. Thanks.
Welcome, Judy. Great to see you.
Hey, Chris. Thank you for having me. Thank you to everyone for being so patient. So I'm here now with everyone on a Tuesday. So I'm looking forward to continuing on the discussion.
No worries. We're actually just on the first question, which is, what are some of the most important recommendations that the Royal Commission made from your perspective? But I'll give you a second to settle in and throw over to Francis.
Thank you, Chris. Firstly, I would like to acknowledge the lands on which we are meeting today and pay my respect to the elders past, present, and emerging. I also pay my respects to the lived experienced people, but also, more importantly, pay tribute to people who have taken their own lives, especially in this COVID period. I was on another forum recently, and I did mention that we have actually lost a number of people for a variety of reasons due to their mental health, and they've taken their own lives. The couple of the questions, the last two people who answered the questions, especially Tanya, or I think mentioned the effect of the issue around deinstitutionalization. I came to Australia in 1986, and thereafter we saw the deinstitutionalization of the major psychiatric hospitals, the new Mental Health Act, and then that followed through the creation of, I'm still classified as a one-man CAT team at times, the creation of the CAT teams, and then various changes. Unfortunately, mental health has been one of those areas where we keep reinventing the wheel, but we're not working together to fix those wheels. And this is, I guess, an important part of this reform. My statement, when I personally, unlike people working for institutions, I went to the Royal Commission as Francis Acquah as personal, not under any organization. So I said I could say whatever I could say because I was not restricted. And I was amazed when the report came because the word I used was that the system was broken. As a mental health nurse of 30 years plus experience, if I call the CAT team today, a young person who probably had just completed their university degree will be asking to reassess the person over the phone before they will accept the person. The question of even access. So can you imagine if an Anglo person who can speak English trying to access service, which I can speak English, I have worked in the system and I cannot access the service. Paris has already mentioned some of the things that they've talked about, but for the people from the cultural and linguistic background, we are so disadvantaged because the issues of stigma. How do we even understand mental illness? And we know, and I've done some work with Foundation House. There are people, there are languages, there are no such words as mental illness. And I go back and I recall back in 1989 when I mentioned the word that, in Africa, we talk about people being mad. At the end of the day, somebody accused me of telling that Africans are mad. People don't even have the language to therefore be able to access the service. So when we talk about being culturally responsive, we need to get to the community and start understanding where the community's understanding of mental illness. The trauma that people have come through from refugee background, the process of migration, the issues around employment. I'm in the process of doing some work in the drug and alcohol for youth employment. One of the people who apply for a job has PhD for a youth employment. The other person is a medical doctor whose qualifications are not recognized in this country. So when we are talking about being responsive and being culturally sensitive, we need to start understanding the community, bringing in the people with expertise in these areas to help with the reform. It's okay to just talk about it and do nothing. And that's what we've done in the past. We've talked about things, but on the grounds, nothing happens. We talked about allowing cultural competencies. Well, when we are even employing people to come in and deliver these programs, I'm sorry to say, we then employ the white people or the Anglo people. I have been in seminars where we've said they've going to talk about African youth. And I was shocked, the presenter, and he had no knowledge about the process of refugees coming through different countries to arrive here in Australia. So in order for us to fix this broken system, yes, the recommendations that have been made, but they have to be put into practical sense. There have to be people who are working in the sector to be part of this decision-making. The funding processes needs to change. It has to be not working just in silos, but through partnerships to be able to actually have the funding, and not for the 6 months or for 1 year, but for a significant length of time. So in short, your question of the first recommendation is really, really as people from the non-English speaking background or the COD community, being able to stand up and advocate so that we all can receive services like any other Australian. currently I'm working in the NDIS, and that is something which is making a different mark, but there are still gaps for non-English speaking people. I have over 50 staff. And when we talk about workforce, and I calculated, I have people from 24 different countries. And that is a reflection. When you walk into our office, sorry, this is not my pajamas I'm wearing today. I thought I've added. This is how I dress to work on a daily basis, maybe minus my scarf. So let's start changing that paradigm so that people will feel welcome when they arrive there. They can relate to somebody. They can get understanding of what services are being provided as well. So I'll pass on to Judy to add some few words or more words.
Thank you, Dr. Acquah. Very, very kind of you. I absolutely agree with everything that Dr. Francis Acquah has said. Basically, around the recommendations that have come through, fantastic. I think it's a great start to call it out there that a lot more structure and services and support needs to be put in place, potentially a whole new restructure of the system that as being put that is considered broken. And so I would also say, similar to Francis, and I assume Paris, I probably missed the best part of what you had, is to also, we now need to focus on putting that into practicality. How is that going to look in real life? And I just think it's mindful that we should be mindful to ensure that multicultural and mental health is placed in all the different sectors, and people need to think more broadly than just their understanding of mental health in a clinical sense itself. So I think there's a strong need for the education system, for example, to really address the professional development and the understanding about mental health within communities. Then also within the research, we need the data, we need the information, we need numbers to understand, and the scientific evidence to understand where we need to direct our resources and support within particular multicultural communities. And on top of that, the actual clinical services itself, which need to be, as Paris mentioned, trauma informed. It has to be a level of co-design. And lastly, within the policy and government sectors, I think it's really important that there is appropriate representation, especially within Victoria, considering that at the end of the day, when you look at all the population where we have someone who's either born overseas or parent is born overseas, multiculturalism is actually a majority within Victoria. So one of the things that I've been pushing and trying to highlight is that addressing multicultural mental health is not a side issue, but it's actually a mainstream issue that we all need to tackle, especially within Victoria.
Yeah, well said, Judy. Second question for the panel is, what do you think are the challenges and opportunities ahead in the mental health reform process, given the big picture that the Parliamentary Secretary's presented to us here today? Be interested to get your thoughts on that. Might throw over to, who wants to go first?
Just go with you.
Why not? Since I was on a roll, eh? Right. I think that there is lots of opportunity now that it's out there. That mention is out there. We now have a bit of a voice to kick the door a bit more open, so to speak. And I really feel that there's a lot of opportunity for us to ensure that appropriate funding is allocated according to those things I just mentioned before, around ensuring that there's appropriate level of co-design with regard to policy, or having someone at the seat of advisory boards and all that, that there's appropriate funding for research, there's appropriate funding within the education and projects, so that there is appropriate translations and interpretation for information and services for the people out there. So for me, the very first opportunity that I see is to really go out there, kick the door open a bit more, and ensure that the appropriate resources are allocated to our multicultural, multi-faith communities.
And we can also look at, yes, once upon a time, I once tried to talk about the American system of actual equality, but also equity. And we need to look at, let's even think about our demographic areas and also ensure that services actually employ people in those particular areas. I mentioned earlier on about the missed opportunity for credentialed mental health nurses. And if people don't know about that, there was a program called a Mental Health Incentive Program that allowed for mental health nurses to work with GPs or psychiatrists. So mental health nurses were embedded in GP clinics. Now, I'll just give a brief example of work I did with the DPV Health in Broadmeadows. I got there and there were probably 5 clients on the book. I was working there 1 or 2 days a week. I grew the clientele to 50. Not only that, but I was there on a Thursday and a Friday. All the GP and all the clinicians knew that Francis, even the receptionist knew that Francis was there on those days. I saw patients or clients, whatever you want to call them, on the day, if I had room in emergency. I saw clients and gave feedback to GPs straight away. I wrote reports, I did recommendations. And the people knew that there's a mental health nurse here who was going to provide some counseling on the day. That made a lot of difference. The sad part of this reform, the challenges that we have include psychiatrists. Of course, I can make a recommendation to a GP to prescribe a medication, but when we need a psychiatrist review, more recently, trying to find a psychiatrist, it's almost impossible. The minimum charge for a psychiatrist is $550 for the first visit. Recently heard there's $750 being charged for the first visit by a psychiatrist. Now, how many of our clients can afford this? But not only that, the waiting period is 3 to 12 months wait to see a psychiatrist. So thinking through this as a challenge, how do we get psychiatrists? I know that Foundation House now have a psychiatrist there, but how do we, little services, also get psychiatrists to come in and review clients when needed? How do we work with other agencies? I'm not going to be ashamed to say I work very closely with Judy because I send my clients to Judy. I send my clients to Foundation House. So that is how we need to work. And this is how the system also needs to understand. This is where it's so important. And these are some of the challenges that we need to voice out. And so people who are on the screen, online, should bring in these issues directly and practical issues that are happening. Failure for the CAT team to actually respond to clients. I changed my tack. So I no longer call the CAT team because I don't have 5 hours to sit on the phone. In the end, what it affects the system in general is I get my clients to go directly to casualty. So they are holding on, they are keeping a space that could be used for something else. So we need to think about it in a different way. For me personally, my clients, especially people I've already seen, sometimes they ring me, I give them an appointment. I will see them within a short period of time. The system needs to start looking at how people can come in and be seen without those barriers that are there at the moment. The gatekeepers who prevents the people from getting help. And unfortunately, sometimes it's too late. So in short, there are a lot of challenges but let's take this opportunity to use this forum and other forums that are being opened up for us to help improve the service. I'm sorry, I'm not going to be here 30 years later, definitely, but let's hope that, as Steve has said, in the next 10 years, we can use this as the starting point and we can make a difference. Thank you. Paris.
Chris, I mean, I think the challenges are both also the opportunities. So one of the biggest challenges we have is how to claim an appropriate level of space, degree of space in these discussions, particularly in the design phase and the implementation phase. So how do we make sure that voices representing CALD communities or refugee communities or other diverse groups are not just sitting on the edge of the discussion, trying to sort of grab the crumbs of the redesign and the resource allocation process. So what's the ways that we can work collectively to secure a much stronger foothold in the way in which things are designed? And I also think that in addition to the way in which resources are allocated and developed, because a lot of the things that we've talked about have been talked about over the years. There are people on the call like Harry Minnis and the older ones of us like Eddie and Mike Safaropoulos and others. We've all been in these conversations for many, many years. And what happens when there are opportunities to see change is that it's been hard to really claim the space and have the degree of influence that we need to have over there. I think one of the ways in which that can be achieved is through the point that was made earlier about partnerships and how do we operate in a way where partnerships, genuine partnerships, is the mode of operating as opposed to the self-interest, which is often kind of taken shape, particularly where things are competitively tendered and so forth. So I think those challenges in the way in which it's designed, the funding, the allocating the resources, the accountability for whether or not those resources are spent in the way in which they're meant to be spent is a really important issue. For example, just take interpreting and translating services. I remember a long, long time ago, the requirements being built into service agreements and so forth that hospitals and others needed to commit resources to translating and interpreting services and so forth. And really what happened over time was that those resources got redirected to other priorities in the hospital. So they're big challenges for us. And if we can find ways to grasp them and secure an ability to influence the outcomes, then they also become enormous opportunities. The other point that I would make is that they will need thousands more workers to implement this over the next 10 years. And so there is an extraordinary opportunity in that to get as many people from culturally and linguistically diverse communities trained, recognised and built into the system across the board. Because I think really you don't get deeper cultural change in the way in which organisations and services practice without embedding that in some way. And so the fact that there will be so much more money and that they will need so much more in terms of workforce creates a real opportunity. And the other part where there's a substantial investment is going to be in the professional training and development of existing workforces and systems as well. So if we can seize those two, deal with those two challenges, those sorts of challenges, we create real opportunities overall. And the last point that I would like to make about it is we have to really drive the ability for communities to be at the centre of contributing to this discussion. So it's great that all the conversation about co-design or co-production and so forth are taking place. It's fantastic around the emphasis with lived experience. But to give that real strength, we have to be able to engage communities and bring them into the core as equal partners in how things are designed services are evaluated and then evaluated and applied again in the future. So that requires a really strong emphasis on community capacity building and community engagement that's genuine. And again, this is a resource issue because you can't just have, when we want to do this, we ask all of the community leaders or whatever to commit their time voluntarily to doing this when everybody else and every other organisation is getting paid. If we're serious about this, then we have to be able to help cover the costs of people's engagement and treat them as genuine partners. And there have been recent examples where, you know, around the COVID crisis, where the Commission was called upon to help and did terrific work in bringing people from different communities and community leaders into the process and continues to do that. But most of the resources went to other agencies and other organisations that didn't necessarily have the track record with the communities that we were trying to respond to who were being impacted. So one of our challenges is how we work together in order to generate a greater movement to maintain a level of influence over how things are actually applied into the future.
That's absolutely brilliant, Paris. Thank you. I don't know if we're going to get through 3 more questions, but I think we'll go with at least another one. And it would be great to give the audience here today, or the people here today at today's meeting, a chance to ask you some questions as well. I think question 4 is pretty important because it's about the recent experience of mental health in the context of the pandemic. What's been your experience working in mental health over the past year through the COVID pandemic? How has the mental health system responded to people from migrant and refugee backgrounds with mental health concerns? I'm sure there's going to be some, you know, pretty cutting examples that you can provide. So I might throw over to you, Paris, this time first.
Okay, thanks, Chris. Look, it's really easy for someone in my position to be critical of things, but one of the things that I've observed both at a departmental level and across government and on the ground is that there's been a really high recognition about the importance of responding to diverse communities more effectively. We still have the gap, though, in the knowledge of services and agencies in the system of how to actually do that. So there's been a need to do quite a lot of capacity building and training to try to get service systems more responsive in that regard. But I think understanding how to engage with communities. So in our case, a lot of government messaging or government agencies are something that our communities naturally have a degree of suspicion about or unfamiliarity with, given the backgrounds that they've come from and the way in which regimes and governments in their countries of origin or even in countries where they were held as refugees for many years have treated them. So I think part of the challenge over the last 12 months is how do we get those things out there? And there are excellent services getting resourced, but they don't have a track record in these groups. So some of the the telephone services that are available for people to dial up if they're feeling distress, they're great at working with the community, but not really a high level of prevalence and responsiveness, for example, to our community. So I don't recall ever getting a referral from one of those services, for example, and that's in 30 years. So I think, but when you're operating in crisis, departments are trying to get resources out the door quickly to respond to the crisis. So the natural inclination is to lean towards organisations they've already got a relationship with, that are already set up and so forth, and perhaps to overlook the richness of what actually is sitting out there in the community that could be picked up and progressed. So I think, I should also say, from our point of view, we're seeing a lot of historical trauma being regenerated as a result of this crisis. So because, you know, PTSD is an anxiety disorder, the anxiety, and therefore you're seeing a lot of things triggering historical experiences and anxieties. So we're getting referrals, for example, of people who've been in the country for a very long time and hadn't necessarily sought the assistance beforehand. There's a lot of issues when the towers were locked down, and I understand why the government felt the necessity to do that, but it did bring a lot of issues up. For some of our communities, you know, they lived in countries like Lebanon or Turkey or Jordan without necessarily being able to leave the house easily. The children couldn't really go to school. There were attempts at home learning. There was a lot of attempts at faith-based teachings and so forth within the home setting. And so the periods of lockdown, of not being able to participate in school and so forth have kind of reminded people of those experiences from a psychological perspective. And then I think one of the biggest issues that we have to come to grips with as a consequence of COVID is the impact it's having on children and young people from diverse communities, especially emerging communities where they already had disrupted learning. And they arrived with great enthusiasm and hope to be able to develop their education and their skills for the future. And their ability to cope with online or be supported by parents who didn't have any experience with online learning during this period of time has created setbacks for them and has had a bit of a disillusioning impact as well. So I think we really need to lean into the issues around children and young people in the education system. It fits beautifully within the Royal Commission's recommendations in terms of mental health and well-being. But I think that's an area that we all need to concentrate on quite a bit. Thanks, Chris.
You want to go, Judy, first? Well, for me, I'm calling it a spade and a shovel, because I think the funding, and people have been talking about a lot of funding coming into the mental health sector. But the thing is, the funding has gone to the big boys, and the big boys don't share their funding. So Beyond Blue, Lifeline are the key places. And I'll throw in Origin Youth Health. Who calls them? From the core communities. And that's the hope process. Yesterday, I had one call, somebody who actually, well, lives in the northern suburbs, but works in Dandenong and wants to come and see me because of recommendation. I get clients come as far as Point Cook, Werribee, and they wanted to see somebody from their own cultural background to understand their needs. And this is some of the things that we are clearly lacking. And over the last year, like Paris said, I've had a lot of clients coming back because of previous traumas. I've had people come who I haven't seen as far back as 8 years, and they've come back through this period. One of my classic lived experience people who I use as an example not long ago is back in this last 2 weeks. And because I know these people, I'm able to make allowance and see them almost immediately. But it's been very, very tough. Lucky for those of us in this sector, of course, we've worked through the lockdown and we've been mobile. But I've had clients who, in fact, have been working full-time in their positions, but at home and locked in their own home, and therefore don't have even that interaction of getting onto public transport, or for that matter, having that interaction with another human being. They've been watching screen. Some of them, I said, you know, where do you have your lunch? In front of the computer. You know, where they can't sleep. And where do they go back to? Their iPhone. So it's been a tough year for a lot of people. And we therefore need to look at services that can respond to, services that can be able to interact. I know maybe Judy is not going to plug her service, but she's set up a new directory, Heart Chat, which is now producing a place where people can find appropriate mental health clinicians who can work with them. And it's a challenge. I must say, Beyond Blue used to have a service like that. It was off. I know Harry is there, Professor Harry Menes is there. Transcultural units used to have a similar service. It's no longer there. This particular program needs to be funded and funded appropriately so that it's ongoing. It needs to be publicized so that when people need service, they know that, look, at least one of the statements I said when I get famous with the ABC was that people want to speak in their own language. And when people are traumatized, it's easy to express themselves in their own language. So we have to take that into consideration. And in short, it has been a very, very challenging time. Not only seeing people on face-to-face, but some of us, we have to physically go and see people as well. Judy.
Thank you so much for that, Francis, and Paris as well. I absolutely agree. I think as a result of COVID, I'm sure everyone would have noticed as well, it's really highlighted more starkly the gaps that we already knew were existing. So, you know, the gaps in supporting new migrants or refugees that we knew were already there were just now amplified, you know, being timely access to services, for example, and especially what was also quite highlighted is international students, support for international students as well. You know, it went from, as a result of lockdown, we knew there were limited support services out there, and that went down to zero. And so we have, you know, whole cohorts of different populations suddenly not having support and being isolated on top of that, and not really knowing where to from here. So it'd be a very frightening situation for a lot of our particular intersectionalities within our multicultural communities. And I think to compound on top of all of that is just as a result of COVID, you know, the rise in racism as well. So I think COVID has really uncovered a lot of stuff, which I see as an opportunity in the sense that we now are able to see more clearly where the gaps are and use the Royal Commission recommendations to really push for that change. Like, you can't really say that it's not there anymore. It's pretty much in your faces, in our faces, to say, okay, this is where the gaps are. We now see it. It's happened. COVID has absolutely amplified it. And this is how we need to make that change moving forward. So that's a bit more of a starker view. But I guess another also positive spin is it really has also highlighted a lot of the resiliency of our multicultural communities and just the capacity for our communities to band together and support each other when we understood the barriers that have impacted our communities. So it'd be nicer just to leave it on a positive spin as well.
Beautiful, thank you, Judy and panel. You know, I guess yeah, I'll save the editorialising, but I think we're really lucky as a sector to have such esteemed professionals that, you know, can be a really strong voice for all of us. And I agree with Paris. I think calling for the need for us to really be working hand in glove, supporting each other in this reform process to make sure that, you know, our communities again don't miss out. I'm going to throw over to Abby, who's got her hand up first. And if you do want to ask the panel a question, please put your virtual hand up. And I believe someone reminded me, for those who don't know, I thought, you know, most of us would be Zoom literate by now, but there is a reactions button on the bottom of your screen. So just go there to put your hand up. Thanks, Abby.
Oh, thanks, Chris, and thanks, ECCV, for putting up this wonderful forum. Look, I think it's more like her statements and my question. I think the first, I'll probably agree with what Dr. Francis said in regard to services when it comes to credentialed mental health nurse, because from my own experience, I do manage a mental health clinic in Point Cook that has about 3 psychiatrists and 5 credentialed mental health nurses. And I could say there is a lot of the amount of contribution that the credentialed mental health nurses made in this period of COVID-19 is actually, it's big. The impact they made on the clients, because what they do is sometimes they go to the client's house to visit them rather than people that can't come to the practice. And I think that is one of the reforms that the government needs to make, and probably fund that program much more better, because especially when the psychiatrists are overwhelmed, we actually realize that the clients, especially people from diverse, multicultural diverse group, kind of engage better with people from their own cultural background, because our mental health, they come from Africa and some other countries as well. And I quite agree with what people said in regard to, when we look at the data from my clinic, we have 45% of clients that were doing well 10 years ago and never engaged with the practice, with the clinic and service, now coming back, and they're actually worse than when they actually left. These are people that are doing well. And I think the government has to look at a way of supporting the private practice and private clinicians who are actually providing service directly to the multicultural society or the ethnic society. But my question will be, in what way can the government support the private clinic or the private organizations who are actually in direct contact with people that are having issues with mental health?
You're asking the wrong people. I mean, this is a point that needs to be brought back to the table. And as you know, unfortunately, Steve had to leave. But that's exactly what we all say from here, is that link that is missing. You have a credentialed mental health nurses, and probably they are engaged with the PHN. Now, for me, I get paid $56 an hour, and I write a report and give it to the psychiatrist, and the psychiatrist get paid $550 an hour. Recently, one of my colleagues, Richard Lackman, has done some calculation around these issues. And the majority of the federal government funding during this period has actually gone to psychiatrists. About 80% of the funding has gone to psychiatrists, and Judy, a little bit to psychologists. Social workers, not looking. Mental health nurses, not looking. So while we are looking at Victoria, Victoria also needs to look at how to take advantage of, we're talking about a lack of workforce or the need for a bigger workforce. One of the other issues that has happened with especially mental health nurses, sorry, social workers, but I'm hammering on the mental health nurses, is that our generation is all passing. The credentialed mental health nurses have diminished because of 3 years ago, once again, the federal government changing the funding model, where it was directly to the GPs and the psychiatrists. Now the money has been given to PHNs. And for example, in the eastern suburbs, there were up to 23 or 28 psychiatric nurses working, credentialed nurses working there. The funding was changed and it was left with only 5. 23, they all retire. I'm not saying they're actually back in the workforce. They actually retire because they pass certain age. And that's something that we might need to look at. Steve talked about getting Cert 4 in mental health nursing. Now that's a 6 months course. Everybody can do that. But we need people with expertise and experience as well. So we need to be able to sustain those who are already in the field and who, like somebody said earlier on, will need supervision as well to be able to actually deliver the quality service that we require, not just the earpiece hearsay. I want to see whether anybody else has any contribution on those points.
Abby, I think anybody, whether it's private practice or a non-government agency or a government-funded service, can still work in partnership together. And I think that one of the challenges that we face is how do we find ways for those partnerships to occur? Now, we have 5 or so psychiatrists that do sessions with us. We don't pay them. They bill through Medicare. We coordinate the clinic for them to see people through and facilitate those contacts. That's an example of working with private practitioners. The networks of general practitioners that we work with include both doctors employed in primary health settings and community health centres, as well as in private practice. So I think when we're talking about partnership, we can't just talk about it operating within ourselves as a non-government sector, because a lot of the resources and the expertise does sit outside of the non-government sector, or the resources that are outside of the non-government sector have the capability to support what we're doing well also. Now, it's not always straightforward in terms of how people get how that occurs, and we often need people operating in the private sector to apply a bit more flexibility to how they might engage on a case with us or whatever the thing may be. But I think when we're all talking about partnerships, I think that for me, that doesn't preclude partnerships with private practice. In fact, I think they are an essential component of that.
Do you have anything to add, Judy, to that question?
No, I think you both of them said it pretty well. I guess at the end of the day, when it comes to funding, there's never enough funding, is there? But I do definitely want to highlight with what Francis mentioned is the importance of the diversity of mental health professionals that are out there, and how it's important to recognize those, not just psychologists and psychiatrists, but also the really great work that mental health workers, social work, and even occupational therapists and so forth do as well. So that's my little contribution.
Thank you. Surya, I think it's you there. Do you have a question?
Yeah. Basically, you see, one of the barriers the migrant communities have in becoming mental health workers and nurses is what is called the APRA condition. They insist, even after completing the courses, unless they get level 7 in English, they are denied registration. So that is an issue. Plus, there are some of the nurses who come from overseas, their qualifications are not recognized. So one is English, insisting on level 7. I know people who have completed the nursing courses, but because they got 5 and 6 level only and not 7, they are denied employment. We need to increase migrant communities to engage in this space. But barriers are not skills. English language. Why do you want 7? Why can't 6 be enough? So I think that is definitely a challenge for us. One is to recognize the qualification that people bring from overseas, plus the imposition of level 7 to practice, to register as a nurse, is a barrier for a number of migrant communities, especially the first generation migrants, not the second generation. I think that is, because as the speakers have said previously, we need to get whole communities to be part of the sector so that the patients can be comfortably engage with the nurses. But that doesn't materialize because the APRA condition. Thank you.
It's a great point. Who would like to respond to that comment?
Well, I think it's a really good point. I think there does need to be a bit more lateral thinking about what we value and how we value it. And then if there is enormous potential there, but there's a challenge like that one, then the issue isn't to shut them out of the system. It's to capitalise on the enormous contribution they can make and then do what we need to do as a part of the development and training to lift any areas where there may need to be some assistance in. But the value of that experience that they have and the cultural kind of relevance that they bring into the system is phenomenally valuable. So just, cutting that out because I haven't reached a particular level, as opposed to seeing that as a gap that the system has at the moment. So let's bring them in and find other ways to work through that. It just seems to be very short-sighted from my perspective, which is why having people like Suri and others contributing to the design and the development becomes just so important in the process. And I'd have to say there are a lot of people arriving from overseas with skills and qualifications in these areas that don't get recognised. And there's got to be ways of capitalising on the wealth of that. I mean, I've sat in rooms with people from different communities, and there are psychologists, there are specialist surgeons, there are general practitioners, there are pharmacists. They can't break into their field here. And it's, if you think about what we're losing as a society by not being able to garner that expertise and incorporate it into what we do, it's actually enormous, not to mention the impact it has on the mental health and well-being of those people who dedicated their lives to a particular profession and can't pursue it once they've arrived here. So I think those sorts of things become really important for us to consider. And one of Francis's points earlier was about the difference in cultural understanding around language. So there's not words really for mental health or counselling and so forth. People from the communities will understand that and will help understand how to create that bridge. I mean, I never forget a program. We took a group of South Sudanese community leaders away for a weekend to talk about these issues because they were worried about what was happening in the community. And there was no word for translating counselling. And as we talked about it and talked it through, one of the women who was a leader in the community said to us, so what you're saying is that you want us to come and vomit with you. And if you think about that in terms of catharsis and getting trauma out of your system and out of your guts into a forum, it's an entirely appropriate descriptor in many respects. So having people around that can help unpack these issues and attach meaning that makes sense in their worlds becomes really crucial. And if you're discarding them because they haven't reached a particular level in their English language training, then that's just nuts.
Well, I think Paris has already said it all. And literally yesterday, I was talking to one of my staff who is from Nepal. And literally, that's what I was saying to him. I said, if you have any issue, come in and get it out of your system. I didn't use the word vomit, but I literally demonstrated, you need to come in and pour it out. And that's the language. There's the thing that our communities understand. They don't sometimes want all the technical things, but sometimes the practical things. The other aspect of this, which I talk about, is that sometimes when people come to us, they're not just coming for straightforward. They don't even know what is wrong with them. And they will be using other issues as the main problem for them. Physical health problem with their children at school, disengagement with the community, things around employment, housing. And sometimes we spend more time resolving those issues. I don't want to spread these rumors there, but I'm a specialist in dealing with a disability support patient. And clients come to me and we spend, can you imagine? I don't know if anybody, if you finish this, when you finish this, go and download the forms to see whether you will be able to complete that form. sometimes 3-4 sessions that you need to fill in these forms to collect all the information. And the fact of the matter is that once this, maybe for other people, when this particular issue is resolved, their mental health completely resolved. So that's a different issue, but definitely we need to actually use people's expertise in different areas. And therefore, people with other qualifications that has not been recognized can also be used to work in the appropriate areas as well. Chris.
I'll be quick. I couldn't agree more. I mean, thank you, Suri, for mentioning that. At the end of the day, I understand APRA to an extent is to uphold the level of quality and of the services that we as professionals should be providing. But there is that fine balance that comes through of upholding what we consider quality and actually preventing those services and that quality of support to the communities that need it the most. So I absolutely agree with what both Paris and Suri and Francis have mentioned. So I don't wish I had a solution for that, but if anything, it's just to continue the discussion, and hopefully this is what we talk about when we talk about a need to relook to review and potentially restructure the systems that are there. So thanks.
I agree, Judy. I mean, Chris, the issue really, if you take trauma, for example, in mental health, anyone who's been traumatized, no matter what their background, the kind of consequences of trauma around generating anxiety, sleep disorders, panic attacks, creating triggers in people's lives that take them back to the traumatic experience, anxiety and depression. They're all features that, as human beings, are experiences of trauma. It doesn't matter where you're from. The challenge is, how to access that and work with that requires professional skills and capability, but the point of accessing it is also cultural. And because it's cultural, it means it's diverse. And that's why the conversation we're having now about the importance of valuing that cultural appreciation and how that is diverse across populations is so important to a well-functioning mental health system. And that's really what we get to bring into that space, which comes back to the very first question you were asking around, or earlier on, about what we need to do to capitalise on opportunities and address challenges here. So just because you're trained in trauma doesn't mean you're going to understand how to unpack that with a Cambodian person who experienced the brutality of the Pol Pot regime all those years ago, or the experience of someone from an African community where the way in which the community supports itself and each other is different to the sort of systems that we would have here. Or you can keep listing out the different faith-based groups or regions around the world. So the notion of diversity and cultural competency as a critical component of being capable to deliver mental health services is sort of undeniable. And so, and I'm really grateful to you for this opportunity to hear Judy and Francis, Steve and other people reading through the chats and the comments in the chat box. These are the conversations we need to have.
Brilliant. Thank you to our esteemed panel today. Really thought-provoking discussion, and all your practice wisdom that you're sharing with us all here today. I'd like to call on our chairperson, Eddie Micallef, to close, come in and thank everyone and close today's meeting.
Thanks, Chris. And look, thank you very much to the panel. I think we've had an excellent day today. And look, in all my years in public life and with the ECCV, I think this is one of the best presentations on an issue that's really challenging the community that's been put together. So Chris and the ECCV team, supported by the board, I thank you very much for today's event. The Minister, I thought, spoke well and talked about what their program is. And I think the panel responded to what the issues are. So if you marry those two areas together, I think we'll get an outcome. The other thing I'll say is the Mental Health and Wellbeing Act, the submissions close on Sunday. I would ask all those from multicultural communities to not rely on submissions to achieve an objective in getting these issues presented well before the Parliament. As an ex-MP, I would suggest that you lobby your parliamentarians, both state and federal, and all parties to make them aware of these issues. The issues of overseas qualifications, the issue of resources, culturally sensitive, culturally responsive services, culturally sensitive practitioners and so on. All these are key issues. But I think in putting it today together, the transcultural mental health people and the ECCV putting that paper together, getting the health department to support it. Look, I think these issues are in the mix for us to do some more work on. We do have a further forum to be presented later in August, and I think one of the things we've seen today, there's so much information we need to put together, we need to have an output of. And in pulling for resources, I'll just make a plea that the ECCV is one of those groups that are under-resourced and overworked and punch above their weight. All of us from a multicultural community have that challenge. And look, thank you once again for your attendance, your questions, and your support and commitment. So have a good day and keep on the fight.